Today I'll be talking about diabetic mastopathy. Synonyms: lymphocytic mastopathy, lymphocytic lobulitis, lymphocytic mastitis, sclerosing lymphocytic mastitis, diabetic fibrous breast disease, diabetic fibrous mastopathy. Definition: diabetic mastopathy is a rare benign reactive fibroinflammatory breast disease characterized by lymphocytic lobulitis, ductitis, and perivasculitis, with stromal fibrosis, described initially by Sola and Carduri in 1984. It represents fewer than 1% of benign breast lesions. It develops in 0.6% to 13% of women with type 1 diabetes, but the condition has also been reported in men. The lesion normally associated with diabetic patients who also have multiple diabetic complications, such as diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. Few cases of diabetic mastopathy in type 2 diabetes mellitus patients have been reported. It is a self-limited condition primarily affecting premenopausal women. Clinical and radiological appearance can raise a suspicion of malignancy. It is worth noting that it is neither a malignant nor a pre-malignant condition. Raising awareness of this condition is essential to avoid unnecessary surgical intervention and patient anxiety. Pathogenesis. The etiopathogenesis is not completely understood. The pathogenesis of diabetic mastopathy is supposed to be due to a secondary autoimmune reaction to abnormal extracellular matrix accumulation arising from the effects of hyperglycemia on connective tissue with new antigen formation, that is, immune-mediated disorder. The triggered autoimmune response manifests with autoantibody production associated with HLA-DR3, DR4, or DR5, and B-cell proliferation. The lesions appear to progress through a stage of initial inflammation that is followed by increasing lobular atrophy and sclerosis with the resolution of the inflammatory components. The inflammatory components consist mainly of B lymphocytes and only a few T cells. Prominent epithelioid stromal cells are noted. Clinical presentation. The clinical criteria for diagnosis of diabetic mastopathy includes a long-term history of type one insulin-dependent diabetes mellitus, usually more than 5 years. It can also be associated with autoimmune diseases, diabetes mellitus type 2, endocrine diseases, and it can even be found in patients without such conditions. It is widely reported in premenopausal women with broad age distribution, teenage years up to 5th or 6th decades. The lesion usually presents as either a lump or a nodularity in the breast, which is painless or rarely painful. The physical examination of the lump is that of hard, irregular, and easily movable. The lesion can be solitary or multiple, and unilateral or bilateral. It is bilateral in about 50% to 60% of cases. A patient can also have non-palpable lesion and shows only abnormal radiographic findings. Diabetic mastopathy is typically associated with non-tender lesions. However, disabling bilateral breast pain and tenderness may be present that lead to bilateral mastectomy to relieve the symptoms according to the patient will. Theories include vascular insufficiency and localized thrombosis that lead to breast tissue infarction. Differential diagnosis. Radiographic and morphologic differential diagnosis for diabetic mastopathy includes invasive lobular carcinoma due to the presence of atypical epithelioid cells, simple fibrosis of the breast, fibroadenomas with marked fibrosis, mammary fibromatosis, leiomyomas, desmoid tumor, granulomatous lobular mastitis. Investigations. Ultrasound. Ultrasound shows a solid hypoechoic lesion with irregular contours and imprecise limits. Mammography. Mammography shows a symmetrical density, most common presentation. MRI. MRI shows a solid lesion with no precise limits and low contrast enhancement. Mammography generally does not demonstrate a distinct mass, speculation, or microcalcification. Most mammograms are reported as dense breast parenchyma, dense glandular tissue, asymmetric densities, and parenchymal deformity. Mammographic findings are non-specific. In this photo, bilateral X-ray mammograms showing dense heterogeneously fibroglandular pattern of right breast parenchyma with a radio-opaque nodule within. In this photo, there is heterogeneous fibroglandular tissue without evidence of masses, architectural distortion, or calcification. MRI, MRI showing multiple regions of enhancement with no mass. Investigation. It is very important to note that imaging modalities, including mammography, ultrasound, and breast MRI, are largely non-specific and may not definitively rule out malignancy. Tissue diagnosis using core needle or excisional biopsy of the mass is required to establish a diagnosis. Fine needle aspiration, it usually gives non-specific findings. True cut needle is very important and essential for the diagnosis to take a core biopsy. Stereotactic breast biopsy with IV sedation. This is a core biopsy put in a formalin 10%. Gross pathology. It shows hard, homogeneous, white, gray breast tissue. Typically, no distinct tumor is identified. Masses may appear in a wide range of sizes. They can be palpable or only discovered mammographically, and they can occur in any breast quadrant, although they do have a propensity to develop in the subareolar region. This is normal breast showing terminal ductal lobular units and interlobular stroma, intralobular stroma, and these are the targets for diabetic mastopathy with blood vessels. The lobules are composed of acini. This is an acinus. Microscopic features of diabetic mastopathy. It shows dense collagenous stroma, keloid-like with proliferation of benign fibroblasts. Dense lymphocytic infiltrates in and surrounds atrophic residual lobules and ducts. Lymphocytic infiltrate around blood vessels, that is lymphocytic perivasculitis, or in the vascular wall. It is called lymphocytic vasculitis, is a constant feature in and around lobules. Vascular calcification may be present. There is typically little or no adipose tissue or cellular materials. Typically no cytologic atypia. These photos show lymphocytic mastitis. Lymphocytic mastitis typically has extensive stromal collagen with atrophy of acini and dense lymphocytic infiltrates surrounding residual lobules. Low power view shows lobular atrophy with perivascular lymphocytic infiltrate surrounded by dense sclerosis. This photo shows vasculitis, periductal lymphocytic infiltrate with some proliferation of duct epithelium. This image shows perivascular lymphocytic infiltrate and vasculitis. This photo shows atrophic duct surrounded by dense collagenous stroma. Immunohistochemistry. Lymphocytes are typically CD20 positive B cell lineage. The epithelioid stromal cells are positive for anti-smooth muscle-acting KPI positive and a negative reaction for cytokeratin. It is myofibroblastic origin. Management. Typically, no treatment is necessary for diabetic mastopathy, as the majority of the patients are usually asymptomatic. Individuals with this condition should be advised about the condition and how to self-examine the breasts to detect any changes in size and number of breast lumps. If the patient can feel lumps in the breast, the patient should see the doctor urgently, even if she has previously ignored any lumps and attributed them to diabetes, as breast cancer is much more common than diabetic mastopathy. This can be done effectively using a core biopsy, which establishes whether the lumps are malignant. Lesions can be surgically removed for cosmetic reasons or if malignancy cannot be excluded. Prognosis. There is no evidence that diabetic mastopathy predisposes to the development of breast cancer or stromal neoplastic disease. So, if typical histological features of diabetic mastopathy exist at core biopsy, surgery should be avoided because of the tendency for recurrence. The recurrence rate following surgical removal tends to be rather high at around 32% and usually within 5 years of the surgery. Unfortunately, these breast lumps do not go away on their own. However, rare cases may regress. On occasion, diabetic mastopathy is associated with intraductal or invasive carcinoma and can lead to an underdiagnosis in a needle biopsy. Follow-up. Patients should be routinely followed up with ultrasound, mammogram, or MRI and core biopsy if the lesions become clinically or radiologically suspicious. The minimum follow-up period is annual. Once this benign condition is diagnosed, the patient should perform routine breast self-examination and have regular clinical breast examinations. Circular motion, up and down motion, wedge motion. The patient should look for lump, pulled in nipple, dimpling, dripping, redness and rash, skin changes. Implications for practice. Diabetic mastopathy can clinically present as breast masses, raising the suspicion of malignancy. A proper history, laboratory, and imaging workup can establish the diagnosis in most cases. Proper counseling and periodic imaging follow-up can prevent unnecessary surgery in these cases and also save the patient from an ordeal as these lesions can recur following surgery. Surgery appears to exacerbate the condition. Conclusion. Diabetic mastopathy is an uncommon but an important entity. It is neither a malignant nor a pre-malignant condition and should therefore be treated conservatively. Imaging modalities including mammography, ultrasound, and breast MRI are largely non-specific and may not definitively rule out malignancy. Core biopsy under ultrasound guidance or mammogram or excisional biopsy of the mass is essential to exclude malignancy. Surgery should be avoided when possible, as it recurs after surgical removal within 5 years and may unnecessarily exacerbate this benign condition. Thank you.